So good afternoon, everyone. I'm Dr. Chastity Walker. I'm with the Centers for Disease Control and Prevention, where I serve as the Senior Health Equity Advisor in our National Center for Immunization and Respiratory Disease, where all of our COVID work sits. We have, how shall I describe it? This has been an interesting time for public health, and as CDC, helping in support of these efforts with communities. We are grateful for those of you who are here in person and those of you who are out in the ether, who have really dedicated and committed to addressing the inequities and disparities that we've seen around COVID. This second panel is related to the power of partnerships. We recognize that key partnership engagement is core to public health, to addressing disparities and driving sustainable change while we're trying to advance equity. We're all connected, and partnerships and collaborations are necessary for the success of any public health program, policies, and practices, and should reflect the diversity of the communities that we're really trying to reach. And as a fundamental condition, our public health approaches must foster the inclusion of communities and grassroots organizations, along with multi-sectoral collaborations in shaping, implementing, and evaluating public health interventions to ensure that the efforts address inequities that are understood and experienced by those they are intended to benefit. We heard that from some of our peers in our previous panel about the importance of including those communities, hearing their voices where the solutions reside. And so when we're talking about the power of partnerships, we're talking about how, not how do I, but how do we. Historically, the U.S. public health and healthcare system has not centered communities as true partners. And that evidence of that has been made clear during the COVID pandemic, and it's one of the reasons why we're here today. And so we're going to talk to our partners here, our collaborators. I'm pleased and quite honored to introduce them, to hear more about their work in the context of partnerships in addressing COVID-19 disparities. I'll first start with Ife Ikwe, Esquire. No, I'm sorry, I know we talked about it. The founder and chief equity weaver at Pink Cornrows, an award-winning equity research and strategic impact firm, and the visionary of Black Policy Lab. Her team launched COVID While Black, which sought to gather the narratives and experiences of Black people early in the pandemic. Pink Cornrows was selected in 2021 to serve as the equity specialist and community managers of Rockefeller Foundation's Equity Vaccination Initiative, and produced the Equity Playbook, which centers the expertise of community leaders and partners in Black and brown spaces. Corey Hines, CEO of the Center for Independent Living of Broward, a community-based nonprofit organization that provides assistance to people with disabilities located in Fort Lauderdale and Fort Myers, Florida. During the pandemic, the center has been one of the leaders in the state of Florida in providing vaccine access and clinics to people with disabilities through strategic partnerships with local state health departments, disability-led organizations, civic leaders, and sports franchises like the Florida Marlins to participate and promote COVID-19 vaccines and booster shots. Dr. Christina Madison, Chief Pharmacist and Public Information Officer for Wellness and Equity Alliance. Wellness and Equity Alliance is a national consortium of population and public health leaders committed to transforming public health care interventions by tailoring them to the needs of vulnerable communities. Dr. Madison joined the WEA team in the fall of 2021, following her leadership facilitating operations and logistics of over 12,000 COVID-19 vaccines to Southern Nevada residents at the height of the COVID-19 pandemic. And WEA knows firsthand the benefits of strategic partnerships through their work providing services to asylum seekers and migrants at the U.S. southern Mexico border. And last but not least, Herman Quinonez, Neighborhood Development Director for Every Neighborhood Partnership, which is an inclusive, diverse, faith-rooted, community-based organization that works to address the social disparities that directly impact communities and populations in Fresno's South neighborhoods through civic engagement, health advocacy, student literacy, and community revitalization. In response to the pandemic, Every Neighborhood Partnership provided services to community members that lacked access to affordable health care and citywide resources through strategic partnerships with state and local health departments, community development corporations, local universities, and city governments. And with that said, again, please welcome my colleagues and panelists to talk about the power of partnership. We're going to get started with a question where we think about sort of partnership and the principles of partnerships that are characterized by mutual trust, respect, shared knowledge, and shared power. I want to start with Herman. People in the communities they are a part of are deeply impacted by the systems that drive and influence their health. However, they aren't often included in the process to create or restructure programs and policies designed to benefit them. What approaches did you take to ensure the design of your program efforts to ensure that they are driven by community interests, the concerns and needs of the communities, and building on the assets that communities offer?
Yeah, thank you. It's a privilege and honor to be here. Yes, to answer your question, it starts with the foundation, right, of community members, community engagement, and what that really looks like. You really can't do impactful work without the community involvement. So what we did at ENP, not that we were super creative, but we tapped into an existing resource, a network of residents, community members that we identified and built solid relationships over the course of 15 plus years. And during the pandemic, we really would lean on a lot of our experts in the local neighborhoods to be our allies, to be our champions for change. So we included a lot into our program design as we're developing services. And during the pandemic, right, we all had to adjust. Our programs shifted, the way we did community engagement shifted. So we leaned on a lot of our community members to be part of our brain trust to help co-design what does community engagement look like. We invite them into a space to be creative and innovative, and because there are trusted messengers, we didn't partner with them. That was our first strategic partnership, was to identify community members in our neighborhoods to be part of our staff, be part of our collective. So to answer your question is really being open and vulnerable as an organization or institution, that there's no fear there that they're not going to change all of it, right? But we want them to be part of the change as well. Part of the system. So community members was a key point of our emphasis as we develop ways of strategies to impact during the impact of COVID.
Thank you.
Mm-hmm.
So what I heard you say is the programming was co-designed, built upon years of engagement previously, and so it was a natural transition once COVID did come about for you all to ensure that the community voices and perspectives were a part of that in any efforts that you did.
Yeah, exactly. And so even having the space for community listening sessions were facilitated by community members as well. Conducting outreach was also led by community members. So it wasn't us as a staff, it was really leveraging the partnerships in residents to be part of our trusted allies to be out in the community, in the front lines, right? So we're talking about the front lines of the systems that are designed to keep people, our BIPOC folks, down. So we wanted to make sure that they were representatives and the visual representation of change.
Thank you. Corey, Community expertise and effective communication has to be a part of public health planning and execution. Your work with persons with disabilities, how did you ensure the inclusion of diverse voices and perspectives and that activities were brought closer to the community served in the settings that they were trusted, particularly when we're thinking about the variety of needs that come for some persons with disabilities?
Good afternoon. Good afternoon. That's actually a really good question. And what we did, for us, inclusion is about removing barriers and providing accommodations for persons with disabilities. So when you mention the first start of effective communication, one of the things we did, we have a huge population of individuals who have deafness. And so when we had our first vaccine clinic, we had 2 sign language interpreters available at the vaccine clinic to be able to interpret what are the forms that they're filling out and how are they going to communicate with them about the effects of the vaccine after they do take the vaccine, what type of effects would happen afterwards. Additionally, there's other, as we speak about providing, removing barriers and accommodations for persons with disabilities is vast because there are multiple number of disabilities. So wheelchair users, for example, we made sure that our facilities were accessible to people who use wheelchairs. When the vaccine first came out, there were lines around the corner at public parks, and there were lines at other places where people were trying to get the vaccine. Well, someone who have a special need, they're going to need to be able to sit down. They're going to be able to, take a break. And, if they're there a long time, they may need to use the restroom. Well, your facility should have a restroom that is going to be accessible to wheelchair users and other people with disabilities. But for us, really, it's about removing barriers, providing those accommodations. And because we are an established entity in the community that provides assistance to people with disabilities for the past 30 years, it was a natural invitation for people to come to our centers, get vaccinated, get assistance that they need, and we became that trusted advisor or that trusted entity for them to receive the vaccine, have health equity, and and flourish. So that was sort of our approach in terms of the effective communication and providing those accommodations.
Absolutely. I can imagine. I was reading some of the work that you all did around multi-sectoral collaboration, working with sports teams and franchises in your area. How were you able to leverage those opportunities and partnerships to address the many barriers that you mentioned that come for some persons with disabilities?
Well, in terms of the power of partnerships and being able to do that with a huge major franchise like the Florida Marlins, a Major League Baseball team, the partnerships we created over time changed. So what happened during the first vaccine clinic and towards the last vaccine clinic since 2020, many of the partners changed. Many of the partners have been terrific partners. But what we did was we came up with a strategy. We said, well, we are doing all these vaccine clinics and they're working out great, and people are trusting us and they're coming to our center to get vaccinated. But what if we could tap into reaching a larger segment of the population? And so one of the things, we actually have a annual fundraiser with the Florida Marlins during the anniversary of the Americans with Disabilities Act. And so we used that date to promote the vaccine during that time. And so the Marlins were great in announcing, when they announced our organization as the nonprofit organization of the game, they also said, if you wanted to get vaccinated, please contact the Center for Independent Living of Broward, provided our information. And so that went out to roughly 11,000 people. So that was the strategy we used for that. And we also did the same with other events. We looked for other events that were already existing and going, and be able to reach more people who have disabilities to obtain the vaccine.
Thank you. Ife. Racial and ethnic groups, particularly Black and brown communities in the United States, have been disproportionately affected by COVID. I've experienced that personally. I lost my younger sister to COVID in August of 2020 at the age of 29, before there was a vaccine. And so I recognize what it does to a family, and many families, the impact of that loss in the longer term implications of how COVID has affected Black and brown communities. How do we motivate and inspire communities to be active participants in addressing health inequities?
So first, I want to say I'm sorry, doctor. And for the record, because I know she's watching, my name is Ifeoma Ike. Everybody calls me Iffy. I'm the daughter of Bernice Ike, who at one point in time was known by, like many of our family members, as an essential worker. And so I actually want to start, if we can, just clap for all the nurses, the DoorDash people, all the people we lost. And that's important because even as we were seeing mass interventions in our communities, so many of us had already lost people, and that story got lost. And many of those individuals were partners first before they were lost. So when I think about what motivates our community, I'm going to invoke a lot of what came from the first panel. And thank you, Abigail Echo, Hawk, for starting with truth. Because to motivate communities without truth is a short-term strategy. It doesn't work. We haven't fixed anything in our community without acknowledging history, without acknowledging that communities are right. And if we're talking about sustainability, sustainability is about what sticks behind. So let me just talk about, I think we're still in the United States of America. Money motivates. I just want to put that out there. Money motivates. We are not just talking about partners. If we're honest with ourselves, even on a funding level, partners in spaces like this are revered. We love talking about them. But when it comes to funding, when it comes to identifying the gems within our communities, they are not seen as the same as, in many ways, the doctors or some of the other interveners in our communities. And that is not to discredit the doctors. That means that we have to figure out both language and the resources to equify, as I like to say, those that are doing the work. So we actually need to think about what are the resources that are there to motivate people to continue doing this work on a large scale. And if we don't actually address what we inherited before COVID, then we're going to miss how we're going to prepare for the next pandemic. Because we're not just talking about COVID at this point. We are talking about resiliency that in many ways has always been driven by unacknowledged genius on the ground, underpaid community leaders. And right now, and I'm want to shout out Dr. Noha in Oakland and a lot of the other spaces, Anna in Chicago, and many of the other cities that we had the privilege of working with. We also need to recognize that we have a completely different healthcare system. We have a healthcare system that is your auntie. We have a healthcare system that has, worship leaders and yoga instructors. And they are no longer just community leaders or partners. They are the healthcare system. So we actually need to think about how we're defining what medical care looks like, but also what communal care does to healthcare. Because we have a health system that had no care. The care comes from the community. So there has to be a price point on care. So the motivation starts with acknowledging what communities are already doing, really being honest about, in a capitalist society, what motivates and how do you keep people in the spaces to do the work that they're doing. And if we're talking about sustainability, which means preparing for the next pandemic that's coming forward, I think now is the time to not only invest in identifying what worked, but pay people to talk about what worked, because it is still laborious to talk about pain and loss and to not compensate or acknowledge that that is re-traumatizing some people, even though many of us benefit from those insights. So I'll stop there.
Thank you so much. Your sentiment resonated with me around how the composition of healthcare has changed and who is providing care and what that means. And so with that, we need to have a shift in thinking about what that looks like, who is responsible for that, who can serve as a catalyst in communities to address the needs of communities for a number of people, especially in the United States, who have no formal tie or connection to what we consider a formal healthcare system. Dr. Madison, in your work as a pharmacist, but also your work in communities, have and/or do you foresee your efforts having had an impact on public health systems change? Because a lot of what we talk about when we think about the need for sustainable change is going to require the change in systems.
Thank you so much for the question, Dr. Walker. So the first thing I want to start with is that we all need to think about leading with community. I want to echo the sentiments of the previous panel by saying when we are making decisions about equitable care, there should be no decisions about us without us. So I want to first and foremost start there. As someone who's worked in public health for over 15 years, I will tell you those partnerships, those relationships, those, late nights, talking with colleagues, communing over why the system was broken, identifying issues around historical trauma, being labeled hesitant without even being asked, opinions about what we actually cared about. As a woman of color, as a parent, and as someone else who's lost someone during this pandemic, I understand that the system is broken. And we're starting with the silver lining and trying to make meaningful change. And we do that by building on the foundations of those relationships. And so I am honored to be here to speak on this panel today, not only as a pharmacist, but also as someone who puts forth equity, because it's in our name, but also because we need to do more for those who can't speak for themselves. Through the work that I've been able to do in my career, and most recently with my work with Wellness and Equity Alliance, I've understood that those who are most vulnerable need us the most. And ultimately, as a society, we will be judged based on how we treat those individuals. So when we think about who comes to this country and who wants to be a United States citizen, we need to think about how we're treating them. And so the work that we did at the border through competence and bicultural and bilingual services, by impacting the community and partnering with individuals such as the City of Laredo Department of Health, CBOs, the Holding Institute, ICE detention, Border Patrol, the Quinonez. That's what we need to be thinking about, is how are we going to make sure that individuals coming here seeking a better life and immigrants and refugees also have an opportunity to thrive. Because the last time I checked, this was a global pandemic. And the pandemic doesn't see borders.
Thank you. I wanted to follow up, please. I wanted to follow up. We've seen the value and importance that pharmacists and pharmacies, FQHCs in communities where people live and thrive and do their day-to-day living, the importance of how they've been able to serve during this public health crisis. How do we sustain those efforts for pharmacists and pharmacies specifically, as an extension of what we know as healthcare providers in communities where people live, work, and play?
So the first thing I would say is one of the most amazing things that we saw firsthand during this pandemic is that almost every American was within 5 miles of a pharmacy and had access to testing, vaccinations, and oftentimes treatment in the beginning of the pandemic. And so from a sustainability standpoint, I will echo the sentiment of my co-panelist. We need money. We need money for sustainability. We need to make sure that pharmacists have working conditions that are at an opportunity so that they can work at the top of their licensure and that they are not scrambling to fill prescriptions on top of doing vaccinations and doing testing and helping with therapeutics. Also, we need to codify the provisions that the PrEP Act put into place, allowing for expanded scope of practice of pharmacists. The last time I looked, I believe that all individual states have the ability to declare the end of the COVID-19 pandemic. And with those, all the provisions that your friendly pharmacist that is now providing you with all those wonderful services is going to go away unless it's codified in state legislation or at the federal level. So I would say from a policy standpoint, we need to make these things permanent. And not just for COVID, but for other services. Before, the last pandemic, which was H1N1, less than 20% of all vaccinations were given at a pharmacy. And now, over 80% are given at a pharmacy. And I just looked at a most recent statistic that showed that over 50% of all COVID-19 vaccines have been administered by a pharmacy or a pharmacist. So we need to be able to empower the profession to be a public health pharmacist and to be an essential portion of the public health workforce.
Absolutely.
So finances, money, and then also policy to make sure that these provisions are in place so that we can not only survive but thrive for the next pandemic.
Absolutely. I want to open this to all of you and then certainly leave time for questions for our folks in the room. How do we build communities, organizations' capacity to respond to public health emergencies such as COVID and others, in addition to confronting other pressing needs going forward? If you had to share one key thing that we need to do that has to be done, what would that be? Dr. Mattis?
Community health workers. We need to expand the ability of more community health workers, right? Because we need to lead with the community. And if we have people who look and sound like us, know our language, know our customs, know our cultures, we're going to be able to impact and make meaningful change. And not just that we need more community health workers and development of that portion of the public health workforce, but also that we need to compensate them for the work that they're doing. So that is the one thing that I would say that we can do, that we can build upon, that will be there and can come to the aid of our communities at the drop of a hat. We've already heard many of the other panelists talk about how people who were unlikely partners, unlikely health heroes, came to the forefront and were not just, there because we asked, but because they wanted to, and they wanted to be there for the community good.
Thank you.
If I could just build upon that, because absolutely, I think we can't get around money. I will say also, I would love to say that I trust that just identifying, those who are doing this work is enough. We have to really make sure we're going through this through not just an equity lens, but a justice lens. And what I mean by that is that we often don't talk about the repair that's needed while we're doing this work. The people who make decisions as to who are the people that are valuable and important in our communities often don't look like the people within our communities. And that is a funding issue, not just a public health issue. So I would say, in addition to what Dr. Madison raised, and I am appreciative, I see Greg here from Rockefeller Foundation. It's not easy work, but we have to do a better job at integrating and weaving who is at the table, and we have to be prepared for the fact that decision-making is going to be different on the other side. What often happens when we talk about partners is partners are invited to the table, and sometimes they are humiliated and embarrassed when they're at the table. They are seen as other than, or they may have different ideas on what the solution is, and those solutions are seen as either inferior, second tier, or other decisions are being made without them in other spaces, especially as it relates to funding. So I really implore that we redesign. When we say co-design, it's not just having people at the table, it's ensuring that the processes, the practices, the policies, and sometimes we need to wait, right? That the decision at the other side may be different than what your KPIs are, OKRs, and all the other things that have been the traditional ways of success. Success has to be redefined, and it has to be something that we bring people to the table, not just as recipients of funds to do the work, because that's a separate conversation about the labor of what this means on the ground, the overexposure on the ground to our community members, even if they get the money, right? But that means that on the front end, we need to be honest about what are the degrees and the qualifications, what are the things that we use as indicators to determine who is qualified to be at the table versus the people that were on the ground, regardless of their title, to save their community members. We have to reshift then who actually gets to make the decision as to who is a community health worker, who does deserve to be compensated, and who also deserves to rest and to heal. Like, we haven't really talked about long-term COVID or the many people that are still on the ground that have been impacted with mental health issues and concerns. So we can't just talk about build, build, build. We have to repair, and that can't be an afterthought. So I would say that that has to be a part of the infrastructure conversation as well.
I would say expand the partnership. So we all have a specific level of expertise, and expanding that partnership with other CBOs and other organizations and keep the conversation going. I think what happened during COVID was more groups got together to come up with solutions than ever before. Those same groups may not have come together, or if they did, it's only because of, a certain meeting or a certain conference or a certain issue. But if we keep the conversation going and we've expanded those partnerships, I think that's going to help in the long run. So, I know for us, Centers for Independent Living, I like to tell folks that we're the best kept secret in America. We provide services to people with disabilities all over the country, and it's the largest network of centers, over 400 centers nationwide. In every state, in every community, there is a Center for Independent Living that provides assistance to people with disabilities. And Many people may not know that. So the health equity that people with disabilities faced during the pandemic was, hey, you know, I only have one place to go, and that is a Center for Independent Living, because they understand me. They helped me get a job. They helped me get housing. They helped me become independent. They helped me get married. They helped me in all quality and parts of my life. So I think, you know, being inclusive and also expanding that network is going to help the conversation and build more CBOs.
Thank you. Emma?
Yeah, just to echo for my esteemed colleagues that creating an ecosystem in your city is challenging work, right? Not everybody has a shared alignment. I think the crisis provided spaces where folks who were different, provide different services, different expertise, came to the table. We're also seeing folks who are not at the table, and perhaps they lack the resource, the funding, the technical assistance support, the education. So equipping and doing capacity building is super important too as well. So within the civic infrastructure of your cities, and creating an ecosystem of shared alignments and shared visions, it's hard work and hard conversations need to happen. So providing space for universities to come to the table, local government, health providers, and what we've seen too as well is that mental health institutions also came to the table. Because let's be honest, what COVID did too as well, it's not just the body, but the mental health was also impacted greatly in our communities, which is already a trauma that existed because of the built environments and all the et cetera things that have happened in this investment in our communities. So we've also spent a lot of time addressing the mental health crisis from the pandemic and providing ways and services and creative ways to create peer groups, having residents be trained and learn how to cultivate mental health awareness, programs that are designed just to meet the whole body, the holistic approach to really identifying the well-being of community. So I think creating an ecosystem is hard work, but it's doable. In our city, we have a lot of spaces where not everyone agrees. We all have different frameworks. So to reframe spaces like that is challenging work, but it's very much a possibility.
Thank you so much. So what I've heard from all of you when we're thinking about how do we move forward in the context of partnerships, we need to recognize the importance and value of community health workers. We talk about how much they mean in the work that they do, but we need to ensure that they are recognized and compensated appropriately, and that they have the tools and resources that are needed to achieve what needs to be done in communities. We need to redefine what success looks like. We need to know who is at the table. The right people need to be at the table, and that goes to the need to relinquish power by federal government, organizations, to the communities where the solutions reside. We need to expand our partnerships, what those partners looks like, and ensure that we are being inclusive. And we need to create an equal system of shared alliance as we're doing this work. Thank you all so much. I'm going to open it up for those who might have some questions. We have time for a few questions.
Mike? Yes.
Thank you. I'm Chris Revere. I'm the Deputy Director for Innovation Planning at the Fairfax County Health Department just across the river in Northern Virginia. We were able to deploy community health workers during the COVID response in a very innovative way. We actually had them assist our residents who needed help during isolation and quarantine in meeting their basic needs. And I think the difference for us was that we were able to measure the impact that those community health workers had with those residents. And I think if we want to talk about the future of community health workers, recognizing the incredible work that they did during this pandemic and want to continue that incredible work, we have to measure the impact. So I'd be curious from the folks in this room and in the panel if anybody actually had measured the impact of community health workers, not just having them out in the community, but what was the real difference that they made helping those versus those who didn't have assistance from community health workers certainly could have benefited from them as well.
Dr. Madison?
So one of the things that we've done with Wellness and Equity Alliance is that we actually have a community health worker task force, and it's a national consortium of leaders within the community health worker space. And we also, after we did the work that we're going to speak about later on in the poster session at the border in Laredo, actually have now a new project that is now community health worker led through the Radix program, and that is going to be a measured project that is being funded. So again, I think it's about looking at those grant opportunities and then making sure that you're utilizing data. I know, we have a data analytics partner called RS21 that helped us to really dive in and be very deliberate about areas where there was lack of vaccine access, as well as lack of resources and potential barriers to care like transportation and other issues. And so I think having that data analytics portion, because data really is king, and then also once you do get that funding source, that there is provisions within that contract that there is a data analytics component that can be paid for so that you can do statistical analysis after in order to make sure that you have sustainability in the future.
Thank you. I think we'll have time for one more question.
Hi, I'm Phil Wong. I'm Director of Dallas County Health and Human Services. And just to follow up on that last question, because this is absolutely what we need to be doing, but just want to emphasize sort of a piece, an infrastructure piece that needs to go hand in hand with everything that we're doing, is that data sort of development and capacity for us to be able to measure those things. And we were in Dallas County we've been developing and modernizing our data system so we can get the data at the granular level. I mean, we were looking and targeting initially by zip code and doing mass vaccination clinics with priorities. But then, within those zip codes, there were like people driving Mercedes into our drive-through clinics, and then, people the target audience we're trying to get. So we really were able and had been able to prioritize more, but we needed that more granular data. And so we've been working on targeting block walk efforts and things at the census blocks. And just want to, just reemphasize, because we need to support all of these type of efforts to be able to, with that system of data, to target and to evaluate what we're doing. And just sometimes that gets lost in some of the discussions, but it definitely needs to be hand in hand. But no, this is great work that hearing about today.
And just really quickly on that, I do think that some of it is that it gets lost, and some of it is that communities don't necessarily have the partners to amplify the things that they are doing and that they are measuring, right? So with our project with the Equity Vaccination Initiative, it was multi-layered with partners that were in communications, outreach, but also research. But the research is not always a bridge. So oftentimes data, while we love using the term data is not unbiased. And oftentimes the way money is driven is by the people who are able to tell the narrative through data. Well, that often is not our community, right? But that means our community needs to be asked differently as to how to participate and contribute to data. And we also need to ask from them, what are you measuring, right? So again, I want us to have this conversation around data, but if we're not honest about how data, in many ways, was also what defined how people look like me, whether we were human or not, that history still permeates in our public healthcare system. So we have to be intentional every time we talk about data to also ask the question about, is this equitable, and how do we make it more equitable while we're getting the information? But to your point, I also think that we need to invite community members to be scientists. They are the ones that are measuring as well. So if we're talking about impact and it's purely done on data that is traditional, we are missing people. People are not being counted, right? And so I think it's one of those things where, this is what I was saying, is that partnership is not always seen as a data-centered space. I think it was Abigail that had mentioned cultural rigor. We have to look at cultural rigor as not only a science, which means there are scientists in those areas, but we have to start measuring it as an impact area, right? That people need to be paid for their expertise of what they know about our communities. Coming to our communities and getting information about our community is a science. It is no longer for free. We cannot just go to communities and think that we're getting that for free.
Thank you. So I will just add to that, you know, when we're talking about impact and data, we also want to think about, into the work that you've been doing, the stories that are told by the data. And so the story is equally as important as the numbers that are reflected by that. I want to thank our panelists for your hard work, for being here with us today, and for sharing your expertise and the reach and impact that you've had on the communities that you've served. We all have taken some lessons learned. I would be remiss if I didn't acknowledge my colleagues and peers at CDC and other public health agencies, federal agencies, to support this work. What I will take back with me to my colleagues is the need and importance of how we can do a better job of practicing community engagement from the inside out. We are aligned with you, and we want to be public health heroes as well, just like you all. So thank you for being here. We're going to take a quick 5-minute break as we move to our next panel.